Lesson 3, Scene Assessment and Primary Assessment. One of the first things that we look at upon arriving at the scene is the scene safe? Fire conditions, contamination such as fuel or hazardous materials? Are there any other dangers, people fighting, shootings? These are all things that could happen on the scene. Unsafe road conditions, flooding, electrical wires. These all make the scene unsafe as well. Pre-arrival information may help us with this. If we have a school bus that's collided with a gas tanker truck, we might have the hazardous materials team going just in case. When you arrive on scene, do your scene survey of the scene, walk around, make sure that we identify any available resources that may be needed, what the mechanism of injury was, how many patients there may be, and how many hazards or what hazards they are and what must we do to mitigate them. Even though we teach it individually that everybody's responsible for looking for safety, everybody must look. It is a team effort as well. You may miss something, you may see something, or conditions may change behind you or around you that you may not notice. So it's important that everybody pay attention and everybody must look out for each other as well as themselves. So during the incident, be aware and be constantly evaluating what's happening. Don't just look at first and say, okay, it's safe and go in and assume it will stay safe. If there's an imminent hazard, take the proper steps to protect yourself or to eliminate that hazard. Constantly watch, especially at crime scenes or violent scenes, domestics, things of that nature. People come back or people don't leave and are still around. So always watch out for those patients. Don't assume that because the police are there that they're going to watch out for you. Sometimes they get fixated on the patient and may not notice somebody in the area or somebody returning. Wear the proper PPE, and if you need to, take off or put on more depending on what the situation dictates. They will be specific to the patient, so some things you may need or may not need, and the incident, and those things can change as time goes on. And make sure you dispose of or eliminate those things as well. Don't throw your bloody gloves on the ground. Body fluids, things like that, tend to try to contain them. Don't leave your sharps. Make sure they're disposed of properly at the scene and also inside the vehicle as well. Make sure that we eliminate those so nobody else gets injured later. So with the pre-arrival information, we get the location of the incident sometimes we only get the general area. We may have to look a little bit more once we get there. We also get the nature of the incident, and sometimes they report any hazards and sometimes the number of patients as well. Do not rely on these as 100% gospel. Sometimes these things change. The location of the incident may be eastbound instead of westbound. It may be more severe or less severe than initially reported. The hazards may not be noticed. Sometimes people don't stop. They report it from their car phones while driving away, so they may not have noticed if there were any gas leaks or hazards or how many patients there were. But we try to do a pre-assessment before we get there, and we even consider calling for additional resources early, putting the helicopter on standby, etc., just in case we need them. Weather conditions, especially lately. Here it's been hot and dry in Florida, but we know in Florida it can rain a lot. We get storms, we get lightning, we get all sorts of weather conditions that can change on a daily basis or even minute-to-minute basis. Keep an eye on the weather. Traffic conditions. Traffic control is important as well, and the time of day. Don't assume that because it's 3 o'clock in the morning and nobody's on the road at that time that you're safe. Sometimes that one driver is not paying attention and can cause or drive through the scene or cause injuries as well. So always be aware of where you're at, what's going on around you, what the conditions are, and what's changing, and take the steps to protect yourself. On scene, we're going to do an assessment of the scene as we arrive, usually before we even get out of the vehicle. What do I see? What kind of damage? How many vehicles? Do I see people hurt, people walking around? Sometimes it's hard to tell who's a patient, who's a bystander, who's a helper, which vehicles stop to help, which, and all these things. So we're going to at least just kind of look around and see what we see. When you open the doors, do you hear anything? Do you smell anything? Do you see any hazards? Does anybody tell you? Usually if there's a gas leak or fire, people are very quick to tell us, but not always. All right? How many people were involved? Any access issues where we may need to do some extrication? And do we need any additional resources? Do we need more ambulances? Do we need air transport? Do we need hazardous materials? Do we need police? What FP&L or power companies for the power line issues, electrical issues, utilities, gas lines. Those are all out and about and can be damaged during accidents, during vehicle accidents, during incidents like this. When we look at the mechanism of injury, remember that energy cannot be destroyed. It is transformed or transferred from one object to another. So that major impact that you see into a vehicle didn't just stop right there. It continued through the vehicle into the passenger, or the passenger into the dashboard. The energy went somewhere, and it generally caused some type of damage to the patient. Compression of the tissue can cause tissue such as liver tissue, kidneys, those can be damaged. Tearing, where they can actually be ripped. And shearing, which can occur in places like the arteries, like the vessels, like the big organs, or even in the brain, where the shifting of the tissue can cause shearing or damage of that tissue. Blunt trauma, what we typically see in motor vehicle crashes, pedestrians who get hit, or people who fall, sports injuries, and even blast injuries. You see this patient here being struck by the vehicle over a wide area from his leg, all the way up the hip, all the way into the side, and even his arm. And then when the patient falls over or goes flying down the street, he's going to hit the ground again, and there's more blunt trauma. With penetrating injuries, they tend to be more point specific, and that point can continue through the body, or it may change if it hits bone or something else. What was the velocity of the object that was going in? This arrow in the abdomen would be more of a low impact, less likely to go in and all the way through the patient, as compared to a rifle, which would be a high energy and more likely to go through and out the other side. How far away was the patient from this energy source? If it was an explosion, which we previously said can cause blunt trauma, there may also be penetrating trauma from shrapnel, objects, etc. And the closer you are to the explosion, obviously, the more likely the impact would be a high energy impact, as opposed to the further away, it would dissipate over time and there would be more of a low impact. And what direction or path did this travel? Did it go straight across? Did it go up? Did it go down? Did it go through? We're not going to CSI and put the little plastic or orange tubes in people to try to figure out the exact trajectory, but we do want to try to figure out what direction it was going or what path it may have taken through the body. How many patients are involved? We may have to triage. Generally, we will do a simple triage and rapid transport or START type of triage. Who needs attention first? Generally, it's those red tagged patients. Do we have enough resources available? We're going to need more ambulances if we have 15 patients or 20 patients. Can you gain access to the patient? Is it a motor vehicle accident where you can simply open the door? Or is the door closed and there's damage that prevents it from being opened, in which case you may need extrication? We may need extrication in building collapses and things of that nature. Sometimes the patient can self-extricate them. Sometimes we may have to extricate them with some assistance, heavy machinery, extrication tools, etc. And your initial impression, which we're going to do before we do our primary assessment. So as we walk up to this patient, does the patient look sick, not yet sick, or not sick at all? If they're sick, a critical patient or high acuity level, maybe that red tagged patient if you've done a triage. Not yet sick, maybe they have some injuries and they're okay, but they're not yet deteriorating. Or that not sick patient who has very minor injuries where even if they didn't receive care for a while, probably would suffer no ill effects from it. Those green tag patients, the walking wounded, maybe they have a minor finger injury or a small cut that's not bleeding. Those patients probably can wait and are not really sick and probably will not become sick. So we talked a little bit earlier in the previous slide about the machinery of life, how all of these things depend on each other. Airway, breathing, circulation, and the energy that is required. The primary assessment is going to look at those things, airway, breathing, circulation, and also disability, and we're going to expose our patient. The assessment is performed to identify those life-threatening issues. And those issues that are identified should be managed and corrected as early as possible, even while your assessment is continuing. Remember, this is not an individual event where you have to do all the assessment and all the work. You have other people with you. If you identify a condition, have someone correct it while you continue your assessment. Some of the things may not be visible early. We talked about internal hemorrhage. You may not find that until after you're done with your primary and you've moved on to your secondary. But you should, in your mind, be thinking, where are my possibilities, or where might I suffer some internal hemorrhage, or your patient will suffer the internal hemorrhage, and I need to keep an eye on those areas. Abdomen, pelvis, kidneys, those areas can bleed a lot. Those are where we need to watch for vital sign changes and things like that. And traumatic brain injury, which may not present right away, or it may present all of a sudden and quickly accelerate and get worse. Those are the patients we need to watch for. The potential for the change is dramatic in those patients. So airway, breathing, circulation, disability, and expose and protect from the environment. These are the things that we need to do for this patient. This is our primary assessment. And even though we teach it in that A, B, C, D, E pattern, sometimes it will be done by multiple people doing different things at the same time. So while you're assessing the airway, someone can be cutting off the clothes to expose. Somebody else could be checking for a pulse. In this picture here, you see somebody is opening the airway using a jaw thrust, they're holding cervical spinal mobilization, and somebody is checking for a pulse at the same time. They could also be checking skin color, temperature, etc. Right? You could be talking to the patient to determine their level of consciousness using the AVPU. So you are maintaining airway and doing disability at the same time, while someone is checking circulation and someone is cutting the clothes off. So you can see we can do all of these things at the same time, but they all need to be done. And if there's a problem with any one of them, we need to try to correct it if we can. So airway should be open, needs to be clear, and patent. Can the patient maintain it on their own? If not, we need to assist them. Are they breathing? Rate, depth, effort. Is it adequate? Is it supplying enough oxygen? If not, we need to assist them. Maybe provide oxygen, maybe provide breathing for them through back valve mask or intubation. Is there a pulse? Also, are they bleeding? Big thing with circulation is bleeding control. So is there a pulse? Do we see any external hemorrhage? If there is, let's control it. For disability, we want to determine the patient's level of consciousness. Generally, we do that using the Glasgow Coma Scale after we have oxygenated them. And we can also use a quick reference tool of the AVPU. Are they alert, verbal, painful, or unresponsive to stimuli? Glasgow Coma Scale was originally created for patients with head injury, but has become our de facto scale for assessing all patients' level of consciousness. We also want to expose our patient and protect them from the environment. So when we expose them, we're looking for any injuries that may not have been readily visible or known to us at that time. We want to look for the hidden penetrating injuries, looking for bruises and contusions of the chest and abdomen, flail chest, etc. We also want to check the posterior as well, so make sure we do that. And we also want to stop any hemorrhage that may be underneath the clothes that we couldn't see right away. We also need to protect the patient from the environment. Right? Remember, patients need to be warm, so we want to make sure that we keep these patients warm. So cover them up and try to prevent any heat loss, because remember, heat loss is one of the legs of the triad of death. So we want to make sure that we keep that patient warm. Okay? All right, so don't get distracted by the dramatic injury, the open fracture of the leg, where you see the tibia sticking out, and everyone's like, oh my God, look at his tibia. But meanwhile, you're missing the hemorrhage coming from the flank or the side that might be his kidneys or something like that. You're missing the bruising on the liver where his liver has been lacerated. That's what you want to pay attention to. The patient not breathing, the patient breathing poorly, and we're all staring at this big open wound. That big open wound may not kill him right now. The airway or breathing issue is certainly going to be a problem. So make sure that we stick with the primary assessment. Make sure we stick with that airway, breathing, circulation, disability, and exposure. All right, so some decision-making things you might think about. Think about the situation. Think about the kinematics, which is the PHTLS term for the mechanism of injury. And make sure we do that primary assessment. Airway, breathing, circulation, disability, and expose and protect from the environment. Think about the severity. Sick, not yet sick, or not sick at all, really. That not yet sick is kind of your yellow category. The not sick and probably won't get sick is your green category. But those sick patients, the ones who are injured, the ones who need help right now, the ones who need intervention, those are your red category triage patients. Those patients need it now, and they're going to need it fast. Does the patient need to be transported immediately? Not all patients are going to need to be transported immediately, lights and sirens, to a trauma center. Some trauma patients can go to a local hospital by ground via regular non-lights, non-siren transport. Some patients may need to be transported by air. Some patients, if the hospital, the trauma center is too far away, that may be a long distance transport. Air may be important for those patients. For those patients, we may want to consider early, do we need to put the helicopter on standby or call for the helicopter? Because that's going to require them doing a pre-flight check, them getting into the air, getting to the scene, and in the meantime, we also need to set up a landing zone, which is going to require more personnel. We need a proper enough spot, big spot, and all those factors that go into determining the proper location, and that's all going to take up time. What are the weather conditions? Is it too rainy? Is it windy? Lightning? Things that may prevent them from flying. We need to package the patient in the meantime, spinal motion restriction if indicated. We may use a long backboard, maybe not to secure the patient, but maybe as a method of moving the patient. Backboards originally, that was their purpose, was to be able to move patients from accidents. Right? The trend continued into using them as securing devices or immobilization devices, but now we're heading back into backboards are not necessarily good for patients. So we may use a long backboard just to move them if we have to carry them for a distance, or we may use a scoop stretcher or a Stokes basket or something in order to carry or move this patient. Does the patient require immediate transport? And if not, then we may do a secondary assessment and transport when we have time to, if there's other patients who take priority. And if this is the only patient, then we will stay and play, as we like to say, and that would be a little bit more of a delayed or a little slower. We wouldn't be in such a rush to get this patient to the hospital. If the patient does not have an immediate priority or primary assessment failure, then we will probably continue with our secondary assessment. Just because patients pass the primary assessment okay doesn't mean that there isn't something wrong or could change, which is why reassessment is so important. When you're going to transport the patient, some of the things to think about and think about early is where do they need to go and what type of care do they need. Are they a pediatric patient? This may dictate a change in which hospital they go to. Do they need a trauma center? Do they fit the trauma criteria that requires us to transport to a trauma center? If not, they may go to the closest hospital. Is there a complete airway failure that you cannot correct where taking them to the closest hospital may be able to fix that problem and then you transport to a trauma center? These are all options and things that can happen, and you have to be flexible and ready for that to occur. Communication, notification, let the trauma hospitals know, let the hospital know you're bringing them the patient. If you've got that patient where you can't get an airway and as a trauma patient, let them know. Be specific. Tell them exactly what the problem is. Don't get too superfluous with all the information and we start giving all these different things that they don't need to know. What was the mechanism? What are the vitals? What interventions have been done? What are you doing? Keep it short, keep it simple. Tell them exactly what they need to know. But communicate early and often with the facility. So in summary, your assessment begins before you get there. There's a lot of assessments that will be done. You will assess before you get there. You will assess when you get there. You will assess your patients. You will get the patients in the ambulance and you will reassess them again, and you'll do further reassessments as you go. Get as much information as you can before you get there to help you. And then when you get there, make sure that you look and see what's going on and compare it to what you already know or what you knew, or maybe what didn't really happen and you don't need. If you thought there was a hazardous materials and you called for the hazardous materials team and you got there and there is no hazardous materials team, then you don't need them. Sometimes you're going to need more than what you initially thought. But look at the scene, start off wide, focus in, find your patients, and start your assessment of those patients. Your initial assessment first. Your initial impression, what do you see? How's your patient look? Age, location, position you find them in. If you find them up walking around on a cell phone, Probably not as big of a deal as unconscious behind the wheel of a car with no seatbelt on and their hair and blood in the windshield. Look for hazards. Hazards can come up or pop up at any time, so don't assume that because it was safe now, it will continue to be safe. Always be on the lookout for things that can change, not just of the scene, but of your patient as well. Airway, breathing, circulation, disability, expose and protect from the environment, that is your primary assessment and the things that need to be done first. Treat them as you find them. Use multiple people if you need to. If you're working on the airway, have somebody fix the circulation, have somebody ventilate. We can work together as a team. Prioritize the patients, sick, not yet sick, not sick at all and probably won't become sick, or your red tag, yellow tag, green tag patients. What kind of transport do they need? Do you have time to do the secondary assessment, or should that be done later or done at all? Package the patient as required or needed by your local protocols and what the patient requires. Transportation method and mode, which should be thinking about early, and call the receiving facility as early as possible. At this time, please review and do the questions for this section. Thank you.